Sorry, you seem to have crashed. Oh, yeah. Okay. Atrioventricular septal defect. It may be a very simplistic way of describing quite a complex abnormality. And I think my experience of teaching fellows that come through and see a wide variety of different types of AVSD is that maybe the anatomy is not so well understood. And I think I'll try and take you through that a little bit more slowly this afternoon. A few general points first. It's quite common. This number was taken from a textbook. I think it's probably a little bit of an underestimate. I think maybe a little bit more than that. It's quite a common lesion if we take all the babies that have Down syndrome, plus the cardiosplenic syndromes, and the ones that have chromosomal normal. There is obviously a whole spectrum, anatomical spectrum, which is what I'm going to concentrate on because that is what is going to influence what you see on the ultrasound of the heart. But obviously there is a clinical spectrum postnatally, which I'm not going to talk about, and there is a clinical spectrum prenatally, which I will just mention briefly because that's your job as fetal medicine specialist, and you're better than me at doing that. So if you look at the clinical spectrum in the fetus, why is it so important? Is there's strong association with a lot of things, contrary to the transposition as we heard earlier on today. So Down syndrome, top of the list, laterality problems, isomerism, right and left, AV septal defects are very common, associated genetic syndromes. It can be, in some families, autosomal dominant, but it can also occur in isolation, like lots of the cardiac abnormalities. So a lot of fetal medicine assessment here when you look at an atrioventricular septal defect. And just to illustrate that, I picked up one of the publications, which is here from Germany, from Berg and Gambruch's group, looking at quite a large series of AV septal defect over a number of years, so nearly 250 cases. And graphing it here is quite striking how many have chromosome abnormalities, trisomy 21 or something else, heterotaxia, a large group, plus genetic syndromes. So an important anomaly not just for the heart, but for the extra cardiac assessment as well. And as I said, you're much better than me at that, and I'm not going to dwell on that anymore. But I'm going to try and take you through maybe some views of heart that you might not have come across to try and explain what an atrioventricular septal defect is. Just before that, two simple definitions, because these words are used quite often. And from the morphological point of view and from the ultrasound as well, there are two main words here, a complete AVSD and a partial AVSD. And people do use sometimes these definitions with different meanings, but that's how I'm going to be referring to. So a complete AVSD is the one that has a single orifice valve in the middle of the heart. And in these cases, you normally have an atrial as well as a ventricular septal defect or ventricular component of the AVSD. The partial AVSD, most people would refer to that, which is probably more common, to only an atrial septal defect. But the partial AVSD basically means the valve that we have across the atrioventricular junction has two separate orifices, and I'll try and clarify that in a minute. If you only have an atrial septal defect, that's a primum ASD, but you can have an atrial and a ventricular defect with two valves, and just occasionally, and this is highly associated with Down syndrome, you can have an AV septal defect where there is only a ventricular septal defect. Another good differentiation is to see if the defect is balanced or unbalanced, because that will dictate a lot of the counseling. The balanced AVSDs normally go through biventricular or two-ventricle repair, while unbalanced AVSD, sometimes that's a difficult decision, but a lot of them will go down a univentricular palliation rather than two-ventricle repair. So the balanced one, the valve orifices, are committed to the two ventricles more or less in the same way, so that the two ventricles are more or less the same size. And an unbalanced one, the valve orifices, one or two valves, are more committed to one of the ventricles. And this will lead to a degree of hypoplasia of one of the ventricles, i.e. one is smaller than the other. So I'm going to try and take you through two different views of heart specimens and compare the atrioventricular junction in normal heart and hearts that have an atrioventricular septal defect to see if that makes it easier to understand. This is a blown-up view of an atrioventricular junction in a normal heart. And we have here the atrial septum, the ventricular septum, the right side and the left side, and we have two separate valves. This is the point of insertion of the tricuspid valve, and this is the point of insertion of the mitral valve, and this is the normal offset of the two valves. And this is a part of the septal structures, which is neither between two atria and neither or between two ventricles. So this septum here is between the atrium and the ventricle. Now, if we take a heart like that and we cut it across, maybe I'll come back here. If we cut that heart anatomically across here and we look down into that, which is what you can do on your 3D, but we can do that on 2D to some extent as well. And this is from a different heart, but it is a cross-sectional view through that atrioventricular junction. And in the normal heart, we have two separate valves, mitral and tricuspid valves, but we also have two separate rings to the valves. So it forms more or less a figure like an 8 here. And in doing that, there is a space in between the mitral and tricuspid valves in which the aorta sits there. So it forms a kind of a wedge. So in the normal heart, the aorta is wedged in between the mitral and tricuspid valves. And this is a key point here in the anatomy of an atrioventricular septal defect. So if we come back to the previous one, I've already mentioned more or less that septum here is the one that attaches an atrium to a ventricle. So it's an atrioventricular septum. So not an atrial septum, not a ventricular septum. And part of that small septum is membranous and part of that is muscular. So an atrioventricular septal defect is really a disruption of this septum very early in the pregnancy, and in doing that is going to disrupt the whole atrioventricular junction. And that is a kind of a four-chamber type view of that atrioventricular junction when that atrioventricular septum does not form properly. As a consequence, instead of having two separate orifices here, we have one valve going across from right to left, and you can see lots of leaflets here. They have much more redundancy to the leaflets than the normal mitral and tricuspid valves. And you can see leaflets that go from one side with chordae both sides of the ventricular septum. Now, if we cut across that heart in a similar way as we did with the normal heart, we have here a ring. So we don't have anymore two separate rings. So we have one valve that goes across. So it's a very complex anatomy here. And because we have just one valve, that does not have that wedged position. So the aorta is pushed forward. So the aorta is displaced anteriorly in all hearts with an atrioventricular septal defect, and that is called an unwedged position of the aorta. So this valve in this example has a single orifice, and that's therefore a complete atrioventricular septal defect. But the valve does not resemble anything like mitral tricuspid valves, and it normally has 5 leaflets, and the anterior leaflet and the posterior leaflet are called bridging leaflets because they go from one side to the other side, from one ventricle to another. And we have mural leaflets and posterior leaflets here. So the superior bridging and this coronary sinus behind the heart here. Now, this is not a heart with an atrioventricular septal defect, but it is a partial atrioventricular septal defect. And you can see that the same hallmark is here. We still have that common valve, common atrioventricular junction going from right to left. The aorta is still wedged, pushed forward, and we do have an anterior bridging leaflet. We have a posterior bridging leaflet, just like we had in the common atrioventricular valve, but different from the complete AV septal defect. We have a chunk of tissue here connecting the anterior with the posterior or superior with the inferior bridging leaflets. And because we have this tissue here, that valve is then divided into two separate orifices. But basically that disruption here is the same in a complete AV septal defect and in the partial AVSD. And then we have the other two leaflets on the right and the left side. So we still have a 5-leaflet valve which has been divided into two orifices. And what happened here is, if you look at the AV junction, maybe you need to look at my hands now rather than looking at the slide. If you have the AV junction here, where that ring is, yeah? The atrial septum is on the top, the ventricular septum is lower down. So if your atrial septum comes all the way down, I need 3 hands, yeah? This is the atrial septum. If your atrial septum comes all the way down, there is no atrial communication. You have two orifices because that tissue is formed by the atrial septum coming down on the junction, and then you may have just a ventricular septal defect. Or if your ventricular septum comes all the way up, you don't have a VSD, but you have an atrial septal defect, which is a primum ASD. And of course, sometimes you can have two valves and an atrial and a ventricular septal defect. So, is that more or less clear? So, is it more complicated? No. I try to put lots of diagrams there so you can try and follow. So I'm just going to show you a few spectrums and some pitfalls and some points to take home, I think, to hopefully not to miss atrioventricular septal defects. Being a cardiologist, you would be surprised to see how many babies are still born, they're still born. They are born alive with an atrioventricular septal defect. Yeah, it's just it's huge, the number of children born with atrioventricular septal defect and Down syndrome, escaping all sorts of screening. So just to help you on that, another paper from, this is not Rabi's one, it's the next slide. So that disruption, the loss of that little bit of the atrioventricular junction, it should really give you an abnormality here. This is a normal, and this paper is trying to measure the distance between the insertion of the tricuspid valve and the insertion of the mitral valve in almost any hearts with an atrioventricular septal defect. And they found a significant difference with a mean value in normals of 2 and a mean values in an AVSD of 0.37. But I think, looking at those two pictures, you don't need to measure anything. It's so obviously abnormal that it's almost pointless to measure. But there are cases of AVSD where it is quite difficult to demonstrate that you have a septal defect problem. So maybe in those cases it will be helpful. What I'm not clear from this paper is how many cases here they had of difficult AVSDs. If they only picked up AVSDs like this, then you are going to find that the measurement is going to be different. And this is Rabi's measurement, quite a number of years now, coming up to 10 years already, looking at the distance between the apex and the atrioventricular junction, and from there to the top of the atrial septum here. And again, those two images are quite different, but normally there is a scooping downwards of the atrioventricular valve so that the distance, the atrial distance here is longer than in the normal heart. And again, there was a difference between the two measurements, but the confidence intervals in the lower end of normal and the upper end of drawing here, it comes quite close. Can't quite read from here. So there are separate confidence intervals, but very close together. Now, I'm just going to go through a few images of an atrioventricular septal defect, and these I don't need to say too much about this. You're used to seeing that. Hopefully, if you see an AVST like that with a large atrial component, there's a secundum AST, there is a ventricular component here underneath the leaflet, and when it opens, a big, big hole in the middle of the heart, so those should not be missed. But I think this lady was picked up at 29 weeks, but missed at 21 weeks. So at 21 weeks, the heart is quite small, and these larger defects are not necessarily very easy unless you magnify and you look at your image very carefully. This is a very old slide, but it shows nicely here the atrioventricular valve, the common valve that I tried to show you on the specimen, the valve open and the valve closed. So people are now demonstrating this on 3D, but we've always tried to do this on 2D images. Now, there's another AVST, but perhaps not as obvious as the other one. The atrial septal defect is much smaller. You can see the ventricular septal defect clearly, but it wouldn't be so clear here without stopping it if we have one valve or two valves, and there comes that point of stopping the image and really trying to scrutinize everything you see, and then many times it's still not easy to say, there we are. It's just a few frames that you can see that it is a common atrioventricular valve, and it makes a difference because a common atrioventricular valve, one orifice there is much more associated with Down syndrome. Now, then we have balanced AVSTs and unbalanced AVSTs, and that balance can be in favor of either the right or the left ventricle. In this case here, we had a larger right ventricle and a smaller left ventricle with a common valve in a complex heart with left isomerism plus other abnormalities like double outlet right ventricle, pulmonary stenosis, and so forth. So it's important when it's so unbalanced like this is going to go down univentricular repair, and a large number of babies in the isomerism group will go down that route. Another example of an unbalanced AVST, now in favor of the left ventricle here on the left side and a smaller right ventricle. Again, a common atrioventricular valve. A lot of these cases, these are not that common, but a lot of these are not chromosomally abnormal. These were chromosomally normal, one of twins, but I have seen that as well in babies with Down syndrome, which poses a little bit of difficulty because the treatment is more difficult long term. So common valve, unbalanced AVST. Now this is quite obvious. This is a primum AST, which is a partial atrioventricular septal defect. In this case, it's balanced, and we have a moderate size atrial septal defect and no ventricular septal defect. So this distance here is really very, very small. So quite easily missed, probably more missed than the complete AVST, but most of these cases are not associated with Down syndrome, although probably about 10% still have trisomy 21. So one of the clues here is the loss of that offset. So you can see that you can stop that picture sometimes, and you could print that image to say that there is a normal offsetting here, even if it's short, although the right ventricle is slightly bigger than the left ventricle in this particular. And the ratio would be wrong, yeah. So I think in cases like this, the ratio probably would be very helpful. In those cases that's so obvious at AVST, it's so obvious why start measuring everything. But in cases like this, so if one routinely measure that, I wonder how many more will pick up. So the distance here between that and that, both the ratio here that Rabbi described, as well as the distance between the insertion of, there is no tricuspid and mitral valves. Those valves are completely different from a tricuspid mitral valve, as I've shown you on the specimen. Now, this is an interesting case. It's a complete AVST. This is 16 weeks, and this lady presented with lots of things: increased nuclear translucency, declined the karyotype in the first trimester, and she came because of the increased nuclear translucency, and there was tricuspid regurgitation. You can see how a lot of the tricuspid regurgitation measured in the first trimester may actually have an underlying problem, such as an atrioventricular septal defect that might not be so clear maybe not in here because we've seen so beautiful images of the first trimester, but sometimes not so easy to demonstrate an AV septal defect with not so many large defects in the first trimester. And that's the picture at 16 weeks. You can see very obvious tricuspid regurgitation, labeled as tricuspid regurgitation the first trimester, but in reality is a common valve with a single orifice regurgitation. And that is really not the main marker here for Down syndrome. The main marker here is the AV septal defect. Now, occasionally we see AV septal defect associated with tetralogy of Fallot, like in this case here. And it is highly associated with trisomy 21 again. And there we have a primum defect, the valve that's going across. And in this case, the ventricular septal defect is usually very large because it has to extend from that part of the inlet up to where we have the aorta, because we have aortic overriding. And we have some of the features of tetralogy here with a larger aorta than the pulmonary arch. So your three-vessel view here has got a pulmonary arch smaller than the aorta, and which is bigger than the superior vena cava. This case was actually referred because of an abnormal three-vessel view, and they had missed the AVST, which is surprising. Now, in this is the same case. It's showing here that bridging leaflet. That's the ventricular septum. This is the ventricular septal defect, and you can see here the bridging leaflet going from right to left, which is a very clear marker for the AV septal defect. And just towards the outflow tract, you can see how that goes across from right to left, across the ventricular septal defect. And that the aorta is pushed forward is a long way from where it normally is. Normally the aorta would be here, wedged between the two AV valves. Now, I'd just like to point out a few of my last few images, it's not going to be very long, that you can quite easily, even if there is a very obvious defect, show a heart that is near normal. And I think that's very frightening in a way for people who are doing their screening. So you could see something like that on a still frame and think perhaps that's normal when it's clearly abnormal with a primum defect, a ventricular septal defect, and a common valve with a single orifice, and you can see a lot of shunting going across in that area of the atrioventricular junction. This is a much more obvious defect, but all these images are magnified. So I think the general considerations we had with the guidelines, as well as we keep saying that in all the courses, magnify your image, narrow your sector, make everything as clear as possible for you to see any problems if they do exist. And we do as well try and see the morphology of the common valve here. This is the left side of the valve, which has three leaflets. The normal mitral valve, which I've shown you in the live session, had that fish mouth appearance. So that mirror leaflet is very important because it will influence the surgical repair. So sometimes we can see that prenatally, but not always. But that's for the cardiologist to sort out. And sometimes you can have an atrioventricular septal defect where one valve here is patent and one is atretic. And this was associated with a feature of hypoplastic left heart syndrome. It's quite old. This little girl did go through a Norwood procedure because he had aortic stenosis as well. She's now 11 years, and Mama was just pregnant recently. And so it's an atrioventricular septal defect with an atretic left side of the valve with a left ventricle that is forming the cardiac apex, but it was the physiology of a hypoplastic left heart. So very complicated cases. This is another case that was referred to me because of cardiac disproportion. Quite a large lady, and once we start playing, there is a degree of disproportion here for 22 week scan, and it was quite difficult to demonstrate the atrioventricular septal defect. But the more you look at that, because a lot of scans is pattern recognition, there is a lot of valve tissue flapping around there. There's much more chordae to that valve, as I'd shown in one of the specimens. And this was also an association with tetralogy of Fallot. And it was, again, trisomy 21. Now, pitfalls, I'm not going to give you too many because I think there aren't too many, apart from trying to get your image very clear. The main one is a left superior vena cava draining to the coronary sinus, like in this case here. This was actually a single left superior vena cava. And because the coronary sinus is so dilated, it does give the impression that you have a primum ASD, and it does give the impression that the two AV valves are at the same level when they were not. But not infrequently, you can have a left SVC in association with an atrioventricular septal defect, so you just need to be very careful to narrow down into that junction very clearly. This is another example of a dilated coronary sinus here. This baby's heart was kind of more in a mesocardial position, although there was no abnormality. Not quite clear why that was. Never found the reason for that. Now, perhaps to me, one of the more important pitfalls is to learn how to look at the heart from different angles. And that applies not just for an atrioventricular septal defect. I think I've shown you that in some of the other lectures today. But what do you think this is? Right, so maybe we're putting our transducer in a certain position, but yeah, just remember that the same picture, if you look at it from different angles, it can look different. Yeah? If you look at yourselves, or if you look at me, people look different, even if you're looking at the same structure. You sure it's a frog? Looks more like a horse now, doesn't it? So scanning is, it's it is an interpretation. There are lots. Calm down. There is. I want to finish my lecture. So, scans, we are looking at image, yeah? So there are optical illusions, and there are things that can be misinterpreted. And you just need to be very careful, all of us, not just you. I have to be very careful as well, particularly in those patients when you can't get views from different angles, and you rely on only one view. So even if certain things are okay, just move around a little bit more to try and see, is it really a frog? Yeah? This lady, they couldn't get a good 4-chamber view on her, and the sonographer came to me at the end of the day, and I said, well, just bring her in, I'm sure it's fine. So she came in, by this stage it was the end of the day, 6 o'clock, and then I thought, well, wait, there is a left SVC to coronary sinus, which you can see here, dilated coronary sinus. And then this is the same lady on the same day. Yeah? Although she was just about 20 weeks, she wasn't the easiest one to scan, but you couldn't really, in this image, say that this is an atrioventricular septal defect, yeah? And that's the same picture, same day, just looking at it in a different angle. And this is the same, it's still the same patient, but just with the color. So even when you put color here, you still can't see really. Now you'd swear almost that this here is a normal atrioventricular junction. And that's the same, yeah? So I think that's my main message in terms of pitfalls. It's a common AVST. This baby was not trisomy 21, and he was born recently and hasn't had surgery yet, but he's doing fine. We had some asymmetry, but it didn't have coarctation. We monitor for that. Now, I put this at the end. I hope Rabi doesn't mind, because quite a few people have come to me to ask when this course is. I have a 3-day course in London. The next one, I said I would put some information here, but it is a ISWOG recognized course, so I think I'm allowed to say it here. The program is on the ISWOG web page, and if you want any information, it's 2 days of lectures and 1 hands-on. It's fitoeco@rbht.nhs.uk. So I hope you go home, make sure that you do know what that picture is, frog or horse. Thank you very much for your attention.